We will be beginning the next topic in medically compromised diabetes from page number 178 of therapeutic guidelines. So diabetes, as a general person knows, it's a increased amount of blood sugar in the body. And first stage management of hypoglycemia will be covering in the medical emergency parts, which is the commonest emergency in diabetic patients. For patients with diabetes, we need to take a thorough medical history and determine if their diabetes is well controlled and stable. So if patient comes to us and not having a controlled and stable diabetes, we will not proceed with treatment, or depending upon, then we have to decide how urgent the treatment is. Consult the patient's medical practitioner if needed. A glycated hemoglobin above the patient's target is an indicator of poor glycemic control. So glycemic targets are individualized for patients. So a common range target, a common glycated hemoglobin target is 553 millimoles per mole, or 7% or less. So below 7%, 7 or 7 less than that, glycated hemoglobin or HbA1c test, most commonly known, is below 7 is safe. Poorly controlled diabetes is associated with post-procedural complications such as infection and poor wound healing. So diabetes make immunity low. It is a kind of a low level of immunocompromise if diabetes is there, and healing of the wounds will be poor. Although the risk of post-operative infection can be higher in patients with poorly controlled diabetes, antibiotic prophylaxis is not indicated. Indications for surgical antibiotic prophylaxis are given later. Then patients with poorly controlled diabetes are at increased risk of periodontal disease. We know that it is one of the complication, periodontal disease is one of the complication of poorly controlled diabetes. So, and sometimes dentists are the one who diagnose diabetes because of seeing such a bad gum health. It is vice versa. They can send patients for blood checkup to get blood sugar test done. And yes, that is one way of doing that. But after taking a thorough history, if the patient says they have not visited their dentist for 7 to 8 years, or more than, they have not been to their medical practitioner, for more than such and such period. So you would advise getting the blood sugar done and getting checked for diabetes. Diabetes may be associated with sialodenosis, which is inflammation of the salivary glands, which can cause impaired salivary gland function. For all patients with diabetes, provide regular dental care, including instructions in oral hygiene and denture maintenance. Consider the possibility of undiagnosed diabetes in patients with sudden onset or progression of periodontal disease, poor response to periodontal treatment, poor wound healing, or recurrent or persistent bacterial or fungal oral infections, and refer the patient to a medical practitioner. So, taking into account undiagnosed diabetes, sudden progression of periodontal disease can happen, and refer these patients to medical practitioner. Then we have dental procedures in patients with diabetes. Use clinical judgment to decide whether a patient with diabetes can be safely treated with outpatient dental department, with outpatient dental treatment, or if they require dental treatment in hospital. This is a very critical judgment criteria they are asking you to pay attention to, that some of the diabetic patients we might need to refer to hospital for treatment. Most patients with diabetes have a routine medications. They have diet, activity, blood glucose monitoring that maintains blood glucose concentration within safe limits. Provided this routine is not interrupted, most dental treatment can be proceed in an outpatient setting. We have this further outline approach to the outpatient dental treatment for patients with stable diabetes, with practical advice to avoid causing hypoglycemia. So this is the table. How do we proceed with the patient in outpatient setting? Before the procedure, determine the patient's usual routine. Have they had medications, diet? If they are coming in, usually we do their procedures in the morning half. So they have had breakfast or not, their activity, blood glucose monitoring. So this is before the procedure essentials. Determine whether any type of activity destabilizes the patient's blood glucose level or control. So any stress or any activity, if it is a destabilizing factor. So this is you are doing in the info gathering part of the course of your conversation with the patient. For patients who are taking SGL2 inhibitors, there is an additional advice which we will go through and determine extent and type of dental treatment required. Ask patients to bring their glucose monitor on the day of procedure if they use one. Then we have the scheduling the procedure. Schedule the procedure for the morning so that any potential sequelae can be resolved during the day. Another important point. So if a patient comes to you late in the evening, you would have to do the procedure next day, recall the patient. Consider the patient's usual meal times and medication regimen and aim to minimize interruption to the routine. So patient, if they are having, means you have to set the appointment that if they have breakfast, they are coming after that before their lunchtime. It is, and it doesn't proceed. Your treatment procedure is not lengthy enough to involve their lunch hours. Avoid extensive treatments and long appointments. Again, the same point. Then day of the procedure, check that the patient has followed their usual meal times and medication regimen and is feeling well. You have to ask these questions that they have taken their meal, they have taken their medication on the day of the procedure, and if they are feeling well. If a patient has missed a meal, if possible, ask them to eat and start treatment 30 minutes later, otherwise reschedule the appointment. Another important point. So they can say that Mrs. Smith came to a known diabetic came and she is insisting that she has come from far and you would insisting you to extract the tooth. So she said that she has not had breakfast. You would have to ask to go out, have a proper breakfast and come 30 minutes later. But if it's already post afternoon, you would not do the procedure the same day because scheduling the procedure is for the morning. So in the morning before lunch, ask them to have a meal and come back within like 30 minutes later. Else reschedule option is always there. Do not give patients glucose or sweetened drink just in case this is ineffective and can destabilize their diabetes management. If a patient feels ill during the procedure, stop treatment, assess their blood glucose concentration, if blood glucose monitor is available, and if unsure, the cause of the symptoms, call 000. For the first stage management of hypoglycemia, we would read it further. Do not allow the patient to leave your care if they are unwell or confused. Then after the procedure, advise patients to maintain their usual caloric intake, activity level, and medications if their mouth is sore. Provide dietary advice on preparation of soft foods if they are likely to have difficulty eating. So this was about how to take care of these patients. So most important things are medication, diet, activity, knowing their HbA1c is less than 7%. Their have had their breakfast, they have had their medicine that day, and then you can proceed. Then we have optimal glycemic control peri-procedurally improves outcomes in patients with diabetes. If possible, postpone elective dental treatment until the glycemic control is optimized. So if it is more than 7, you have to, if it is an elective dental treatment, just postpone it. However, do not delay treatment of acute or infective dental conditions. If unsure whether dental treatment can be safely proceed, then consult the patient's medical practitioner. So if there is a doubt about safety of the dental procedure, the diabetic management impeding the safe delivery of the oral health care, consult the medical practitioner. And sodium glucose co-transporter 2 inhibitors may need to be stopped temporarily before dental procedure. So if the patient is taking SGL2, they may need to stop it. If pre-procedural fasting is required, like GA or intravenous sedation for patient with diabetes, an anesthetist or other appropriate medical practitioner must supervise the dental procedure. So this becomes a kind of a hospital procedure. Then we have dental procedures in patients taking sodium glucose co-transport 2 SGL2 inhibitors. What is different for them? So these inhibitors, example, dapagliflozin, emagliflozin, or ertugliflozin, they have been associated with development of euglycemic diabetic ketoacidosis in patients with type 1 or type 2 diabetes. So they produce ketoacidosis. The risk of diabetic ketoacidosis is increased in patients taking SGL2 inhibitors who have been fasting or have very restricted dietary intake. They have undergone a surgical procedure. They are dehydrated or have an active infection. Now, these inhibitors may need to be stopped before a dental procedure. For prolonged dental procedure or procedures in which fasting or dehydration is likely either before or after the procedure, consider stopping these inhibitors pre-procedurally. Alerts highlighting peri-procedural risk of diabetic ketoacidosis in patients taking SGL2 inhibitors have been issued by Australian Diabetes Society. So this is an area of, being attentive and asking the history of if they are on these medicines, SGL2 inhibitors. If that is there, it might be required for stopping it. But would we stop it, or we would consult the medical physician? So it's best to consult the medical physician than, because it's written may need to be stopped. So may is a very qualitative word. It is neither yes nor no. So you just consult with the medical physician whether to stop these drugs before dental procedure or not. This is the correct answer. Consult the medical practitioner, right? So this completes diabetes management, or how to manage patients with diabetes in outpatient setting. Next, we have HIV infection. So antiretro, it's a complete immunocompromised state with lot of oral manifestations of HIV. Now, antiretroviral drugs interact with many commonly prescribed drugs. Consult an HIV expert before prescribing any drug in a patient taking antiretroviral drugs. Unusual and rare adverse reactions like perioral paresthesia can occur with antiretroviral drugs. With currently available antiretroviral therapy, many patients with HIV are well managed and stable. However, patients with HIV infection, particularly smokers, are at increased risk of oral diseases such as opportunistic infections, periodontal disease, necrotizing periodontitis, oral hairy leukoplakia, oral squamous cell carcinoma, So all these are opportunistic infections or diseases happening due to immunocompromise. HIV-related salivary gland hypofunction can occur, increases the risk of oral candidiasis. So oral candidiasis always happens in the immunocompromise. So just see for it. That is, it's one of the management for oral candidiasis is maintenance of or correcting the underlying situation or disease. Other oral manifestations of HIV include recurrent after stomatitis, intramucosal hemorrhages, and the hyperpigmentation of the oral mucosa. Some conditions are particularly related to late-stage HIV, such as Kaposi sarcoma and oral hairy leukoplakia. Oral diseases and opportunistic infections in patients with HIV infection should be managed in conjunction with an HIV expert. So this is, we are giving a key highlighting answer option that all these diseases, whatever oral cavity or opportunistic infections they have mentioned above, they should be managed in conjunction with the HIV expert. Referral to an oral medicine specialist may also be appropriate. And see, the answers to the questions will be so basic that you would get confused. So for an HIV person visiting the dental clinic, how would you manage or how would you treat? Maybe something as simple as in conjunction with HIV expert, which would look like a mundane thing. When with other big options and stunning options will be given over here. So we have to stick to very, very basics as a general dentist operate, and do run in your mind referral. So most of the times they do not take risk and keep referring for anything which is beyond normalcy levels. Next, we have immunocompromise. So patients with immunocompromise are at increased risk of infection. We know that. The dental management of an immunocompromised patient requires a multidisciplinary approach. So these conditions can cause profound immunocompromise, which include end-stage kidney disease, end-stage liver disease, malignancies, untreated or end-stage HIV infection, and malnutrition. Then we have, these are all causes of immunodeficiency, which are immunocompromise, which we are seeing kidney, liver malignancy, or HIV or malnutrition. Then conditions that can be treated with immunosuppressive therapies include autoimmune and inflammatory conditions like rheumatoid arthritis, psoriasis, inflammatory bowel disease, SLE, organ transplantation, and malignancies. So all these conditions can be treated with immunosuppressive therapies. Now, the degree of immunocompromise affects treatment decisions and the use of surgical antibiotic prophylaxis. For example, poorly controlled diabetes can compromise the immune system, but is not an indication for surgical antibiotic prophylaxis. Conversely, so we are not giving any antibiotic prophylaxis to patients who are poorly diabetic. Okay. Conversely, profoundly immunocompromised patients, example patients taking high doses of immunosuppressive therapy, may require surgical antibiotic prophylaxis. So, like degree of immunocompromise, diabetes does give immunocompromised status, but it is not so complex. It is at a grade in the gradient, in the radar, it is of a lower level of immunocompromise. But if the patient is taking high doses of immunosuppressive therapy, then we'll need surgical antibiotic prophylaxis. So consult the patient's medical practitioner here, specialist or multidisciplinary team to determine an appropriate treatment plan and need for surgical antibiotic prophylaxis. Next, we have chronic musculoskeletal disorders. So pain and restricted mobility are common symptoms of musculoskeletal disorders. They can encompass a range of conditions which affect muscles, joints, bones, spine, and multiple body systems. Okay, so back and neck pain, any widespread regional pain disorders, inflammatory connective tissue diseases, systemic vasculitides, fibromyalgia. Now, patients with pain and restricted mobility due to a musculoskeletal disorder may find extended dental treatment uncomfortable. Modify treatment to minimize the time spent in the dental chair and consider changing their chair configuration using filler pillows or to support neck, hips, or knees. So just make it more cushiony treatment for them. Patients with chronic musculoskeletal disorders may be prescribed immunomodulatory drugs, which can cause immunosuppression. And if corticosteroids are used, we have seen in the beginning of the chapter regarding modifying the dental treatments if we are using corticosteroids. That is, topping up of the dose may be needed if the patient is on long-term corticosteroids, which was more than 21 days, right? What was the dose? Let us go back and revisit. Remember, 163. I remember more than 21 days, but dose 10 or... Okay, we are here. Corticosteroids. Then or more and more than 3 weeks. So here, expected to cause adrenocortical suppression, and so this can lead to adrenocortical suppression, and we need to top up the corticosteroids. Then we have now the next is conditions that can be treated with immunosuppressive therapies, autoimmune and inflammatory conditions. Example, okay, we read this, all right. Yeah. We were here, musculoskeletal. Again, yeah, we were here. If corticosteroids are used, there can be need to top up the dose of corticosteroids before treatment. Some patients with chronic musculoskeletal disorders take large doses of over-the-counter or prescription analgesics, example, opioids. Opioids can cause dry mouth and consequently dental decay and periodontal disease. So particularly if taken with other drugs that can cause dry mouth, for the management of dry mouth, which was given previously, consult the patient's medical practitioner if pain management is required for a dental indication. Patients with chronic musculoskeletal disorders may have prosthetic joints. This is not a specific indication for surgical antibiotic prophylaxis before dental procedures. So this is important area that chronic musculoskeletal disorders may have prosthetic joints, and it's not a specific indication for antibiotic prophylaxis. So artificial joint patient may not be a candidate for an infective endocarditis or surgical antibiotic prophylaxis. Then we have neurological conditions, stroke. In dental practice, first aid management of stroke is outlined ahead. Patients who have had a stroke may be taking antithrombotic therapy. Patients who have had a stroke may have a physical impairment that affects their ability to carry out usual oral hygiene practices. And patients with residual neurologic deficit of the arm can have difficulty cleaning their teeth. So large-handled power toothbrushes can improve the effectiveness of oral hygiene. Patients with seventh cranial nerve weakness accumulate food debris on the affected site and can have difficulty with the denture fitting. So modifications to denture design include a thickened flange, consider an implant-borne prosthesis. The patient must be sufficiently healthy to undergo the surgical procedure and be able to maintain good oral hygiene. Then we have epilepsy. In dental practice, the first aid management of a seizure. Seizure, again, first aid management when we read in the medical emergencies part of this book, we will go. For patients with epilepsy, assess the stability of their condition, including how frequently the seizures occur and what triggers them. At each appointment, check that the patient has taken their usual medication, because omission of doses can cause seizures. Avoid stressful extended procedures. Consider the use of a mouth probe to prevent the patient from biting the operator's fingers or instruments if a generalized seizure occurs during treatment. So some anti-epileptic drugs like phenytoin, sodium valproate, carbamazepine, and barbiturates can cause gingival enlargement or gingival hyperplasia. Gingival enlargement can be minimized with good oral hygiene. So important issue, oral issue with anti-epileptics is hyperplasia, medication-related hyperplasia. This can be minimized with good oral hygiene. However, extensive gingival enlargement requires specialist management. Then comes trigeminal neuralgia. So patients with this trigeminal neuralgia may mistake their symptoms for toothache. Dental pain, particularly pulpitis, is qualitatively similar to trigeminal neuralgia. So when you are taking history for pain, you have to carefully evaluate what type of pain it is and carefully evaluate teeth also. So if the findings from oral examination and tests like pulp tests, radiographs do not suggest dental pathology, or if initial dental treatment does not reduce the pain, consider the possibility of trigeminal neuralgia. So it is a very important area where they expect a distinction between odontogenic pain or a non-odontogenic pain. This is a trigeminal neuralgia is a non-odontogenic pain, which mimics dental pain. Okay, the patient feels that the tooth is aching because of the nerve supply of the teeth is by trigeminal No. Do not undertake further dental treatment or perform invasive or irreversible procedures like RCTs, extractions, unless dental pathology is confirmed. If facial pain is not dental in origin, refer the patient for medical assessment. In patients with unstable trigeminal neuralgia, dental treatment can exacerbate pain even if performed at other sites in the mouth. So, just the touch at the cheek or the lip region in the maxillary alveolus or anything, it can trigger the pain zone, which are called as a trigger area in trigeminal neuralgia. So, treating the area affected by trigeminal neuralgia with LA block can reduce the degree of exacerbation. Next, we have psychological and psychiatric disorders. So the psychological status of the patients can affect dental treatment plans and outcomes. Determine their psychological status by taking thorough medical and medication history, noting the use of and indication for any anti-psychoactive drugs. Patients with psychiatric and psychological disorders may have barriers to adhering to dental treatment, maintaining daily oral hygiene, and attending regular dental reviews. So they are having these, the mind controls us and we also can control the mind. It's a vice versa. So in this patients, very sadly, this regularity of maintaining life in itself is lost. So maintaining oral hygiene and the ability to upkeep for themselves is a bit questionable. Then psychotropic drugs such as antidepressants, antipsychotics, psychostimulants can cause dry mouth. Selective serotonin reuptake inhibitors, which are SSRIs, serotonin and noradrenaline reuptake inhibitors, SNRIs, antipsychotics, amphetamines can trigger bruxism. Psychotropic drugs are associated with many other adverse effects on oral and dental health. Consult the patient's medical practitioner if a psychotropic drug is suspected to be causing an oral adverse effect. Then patients with a history of sedative drug, example, analgesics. These are all a history of sedative drug. Any drugs which are central analgesics like morphine, codeine or anything. Anxiolytics, illicit drugs, or hazardous alcohol consumption may have a tolerance to sedative drugs. So they will, at the low level of prescribing them sedative drugs, they will not be working in them. So they have developed tolerance for some basic level of drugs. So if procedural anxiolysis or sedation is required for a patient tolerant to sedatives, we need to seek expert advice or refer to specialist for management. Then we have substance use disorder and illicit drug use. So illicit drug use can have adverse effects on oral health. Many illicit drugs cause dry mouth and combined with ketogenic diet and lack of oral hygiene can result in dental caries, oral candidiasis, other oral infections. Intake of drugs through smoking increases the risk of oral cancer. Bruxism, jaw clenching, and resultant tooth damage is common in users of amphetamines and cocaine. If a substance use disorder is identified, it is important to investigate the use of other substances because multiple drug use is common. Then patients with a previous or current substance use disorder are at particular risk of developing benzodiazepine dependence. So they can develop these diazepam dependence. Consider the risk or benefit of using benzodiazepines for anxiolysis for dental procedure with them. And there would be a separate section of anxiolysis or discussing about all these drugs of anxiolysis, which is most commonly prescribed are benzodiazepines. But those who are already tolerant to illicit drugs, for them that basic level of pharmacological benzodiazepines won't work. Then we have drug dependent and drug seeking patients may present to a dental practice. Be circumspect if a patient demands analgesic drugs and exhibits a good level of knowledge or a preference for a specific opioid. Be aware of legislative requirements for prescribing drugs of dependence to a drug-dependent patient. Advise the patient to consult their medical practitioner. And then we have respiratory diseases. We will begin from respiratory diseases in the next session.